Hello, everybody. Welcome to Hand in Focus. The theme of tonight's session is new approaches for treatment of thumb arthritis. My name is Harvey Chim from LSU New Orleans. I'll be moderating this session together with Carl Ablin from MGB in Boston. So the first paper we're going to be discussing tonight is entitled Short-Term Complication Rate in Single versus Dual Mobility Thumb Carpal Metacarpal Joint Arthroplasty. And we have the senior author, Frederick Verstrecken, joining us all the way from Europe tonight. It's 2 a.m. in the morning in Europe. So thank you so much again, Frederick, for joining us. The second paper we'll be discussing tonight is entitled Clinical Efficacy of Pulse Electromagnetic Field Therapy on Thumb Carpal Metacarpal Joint Pain, a double-blind randomized controlled trial. And we have senior author Dr. Raymond Cho joining us tonight. Our expert for tonight is David Rush, who is the Virginia Flowers Baker Distinguished Professor of Orthopedic Surgery and Chief of the Division of Hand, Wrist, and Upper Extremity Surgery at Duke University School of Medicine. And Dr. Rush is also past president of the AHS. So we're very honored to have him join us tonight as our expert. So the format for tonight will be for each paper, starting with the author presentation, and this will be followed by an expert presentation and discussion, and finally open Q&A for each session. So please mute your microphones. Please have your camera off while the speakers are presenting. Cameras can be turned on for Q&A, and please ensure your Zoom screen name is your first and last name. We would like to encourage questions from all of you. So please, if you have questions, type them in the chat. This session is designed to be engaging and interactive. So without further ado, I'd like to invite Dr. Verstrecken to start us off with his presentation on this paper. Frederick, please.
Thank you, Harvey. Let me share this. Okay, can you see the slides? So good evening, everybody. It's a pleasure to be here and present our study on CMC arthroplasty. I know this is a controversial topic still in the US, so I'm looking forward to a good discussion. CMC arthroplasty started in the 70s in Europe, and it has gradually over time become a very popular treatment option for CMC osteoarthritis. And what we've experienced over the years is that it provides us excellent pain relief, early return to function, and good restoration of thumb height and correction of MCP hyperextension when that's present. And what we've also seen consistently in different papers is very high patient satisfaction, higher than with other treatment options for this problem. It's important to realize that these implants have gone through an evolution, and when they came out on the market in the 70s, these were cemented implants, and there was a major issue, which was loosening of the cup, which gave them a bad reputation. And I don't think they've overcome these bad reputations in many parts of the world for a very long time. But the implants have changed over the years, and the second generation of implants was introduced in 1991. And these were cementless implants with hydroxyapatite coating. And we've seen excellent long-term outcome reports with these type of implants. Just to quote a few, so there's several papers that provide 10-year plus follow-up with good survival rates. This is one of the papers, and as you can see, the survival rate after 10 years is very similar to the survival rate of total hip replacement that was reported in the Swedish hip register. Now, a register is not a patient series, but still it shows that we are coming very close to the results long-term of hip replacement. However, there was one major issue with these second generation implants, and that's instability, reported in the literature with up to 7%. And this has been addressed by companies by bringing dual mobility implants on the market, similar to as it's been introduced in total hip replacements, with the idea that a bigger head means a bigger jump distance and would, at least in theory, give us more stability and less risk of dislocations. And that's the third generation of implants. Again, hydroxyapatite, ball and socket implants, but with a dual mobility head instead of a single mobility head. Our study the aim was to compare the short-term complication rates of dual mobility versus single mobility implants, with the hypothesis that dual mobility implants would reduce the dislocation rates. And you see the implants on the left is the dual mobility implant, and on the right is the single mobility implant. They have a very similar design of stem and cup. It's only the head that's different here. The indications for surgery are Eaton stage 2 and 3 CMC osteoarthritis with preserved trapezium height, and we want at least 6 to 7 millimeters of trapezial height to get a well-fixed cup. And of course, these patients failed a course of conservative treatment. The relative contraindications, joint laxity, osteoporosis, high demand patients, and the presence of STT osteoarthritis. These are not absolute contraindications, but we discuss this with the patient, and then it's shared decision-making about what the treatment is going to be for that patient. We included all CMC arthroplasties on a 4-year period from August 2018 till December 2022. And the single mobility implant was the RP implant from Zimmer Biomet, and the dual mobility implant was the Touch from Kerry Medical. And all procedures were performed by a single experienced surgeon using exactly the same surgical technique. For reasons of time, I will not go into detail for the surgical technique, but it is essential to get good training doing this procedure. There's clearly a correlation between surgical technique and the risk of complications, and you want well-positioned, well-oriented implants to have a stable situation and a good end result. The postoperative protocol was similar for all patients. They get a bulky dressing for 2 weeks. After 2 weeks, they can start active range of motion exercises, and they get a removable thumb brace for another 4 weeks that they carry intermittently. We see them back at 6 weeks for a clinical and radiographic control, and usually that's the last time we see them for clinical follow-up. The results, very similar demographics in both groups. The complications, clearly a much higher risk of dislocation in the single mobility group, 7 patients compared to the dual mobility group. Other complications, cup loosening, heterotopic ossification, trapezial fractures, and symptomatic STT osteoarthritis were similar in both groups. Looking at the dislocations, all of them occurred in the first 3 months postoperatively. The one in the dual mobility group was treated with a longer neck and a further uneventful outcome. The ones in the single mobility group, 1 was treated with closed reduction, 4 required open reduction, and 2 required component revision, primarily the neck length. So what we've seen is a significantly lower dislocation rate with the dual mobility heads, 0.5% in the Touch and 4.2% in the RP implant. Although the survival rate at this short-term follow-up was similar in both groups, which is consistent with the literature, about 97 and 96%. This certainly surgical technique is essential to prevent dislocations. You want accurate cup position and stem position. You want to remove osteophytes. You want to balance these soft tissues and thorough rinsing to reduce heterotopic ossification. And that will significantly lower your risk of dislocation. So in conclusion, we feel it's an effective treatment for symptomatic CMC osteoarthritis with excellent clinical outcomes and in generally low complication rate. It is a surgically demanding procedure, and training is very important to minimize the risk of complications. And in this series of 352 implants in total, dual mobility implants have, at least at short term, shown superior outcomes compared to the single mobility looking at dislocation rate. Thank you very much for your attention.
Thank you very much, Frederick. That was really excellent. Next, I'd like to invite our expert, Dr. Rouge, to give us his take on this paper. Dave, please.
Thank you, Harvey. And Frederick, it's always a joy to hear you speak. Can you guys all see this?
Looks good, Dave.
Okay, great. So, you know, operative intervention in the United States goes back to the 50s and typically has always been resection with some type of associated stabilization. All of our results over many, many years have shown really excellent long-term satisfaction. And in a recent Cochrane review, really no conclusive data to support one method over another. And this is just one such example, of what this operation has meant to us. And it's amazing that we have put up with it for as long as we have. When I trained was like the late 80s, and we were doing the FCR, and patients took forever to get it better. This is one study out of Australia. It showed patients were still improving at 9 months post-op, which really led to a million different options. Our therapist observed that revision suture suspension plasties got better faster than the LRTIs, so we went to suture suspension plasty. But really, in the United States, our experience with replacement goes back to Al Swanson's experience with silicone prostheses. Some of these results were really quite good, as reported here in this study in JHS, with no frank silicone synovitis, but others demonstrated significant silicone synovitis that spread throughout the wrist, resulting in really poor outcomes. And so they actually concluded in 1991 that they were not going to do this any longer. But really, at the end of the day, we started trying to find an option that was going to be a faster recovery. Artelon, carbon fiber ball, gel foam, palmaris, arthroscopic resection, hematoma distraction, partial versus complete. And now the most recent kid on the block is denervation. But they're all options to try to decrease the amount of time that our patients spent getting over this operation. And really, it wasn't until we started getting data from Europe that we started getting engaged with this option. The first ones were the traditional Caffiniere prosthesis, and my experience with these were primarily subsidence and problems with impingement. The second generation, as Frederick alluded to, were significantly better with cementless prosthetics. But I would encourage you to really look at this article carefully, because many articles that get published are all about describing their data and their data analysis. And this is a great article that describes a surgical technique and what is important in order to avoid complications. And what some of the key points that are made are resection of the osteophytes on the metacarpal, central reaming of the metacarpal, mobilization of the base of the metacarpal in order to allow central placement of the cup perpendicular to it, and the cup parallel to the past line. And so I think it's a great article for everybody to look at, because it's not just about data, it's about technique and avoiding complications. So to Frederick, thank you very much for your time tonight. And I realize it's late on your time frame, but if you could comment a little bit on your selection of a cup shape. I've heard you speak on this before. And also any lessons that you may have learned from the single mobility versus the dual mobility that may have improved your results with the dual mobility, that could perhaps have shaped your outcomes. And then I've heard a variety of different approaches about capsular release versus capsular incision and repair. And your paper very politely avoids the problem and says avoid excessive release, although we emphasize releasing it. So if you could just comment on that, that'd be wonderful for us to discuss tonight. So thank you again for all of your contributions to the literature and for your willingness to be here tonight.
Thank you very much, David.
I'm going to stop sharing.
No, you can leave it on, I think. No,
Okay,
allows
I
me to
will.
see-
I'll leave it on. Yeah, that's
allows
probably
me to see
good. Yeah.
see the questions, but
Okay.
I can comment on the cup shape first. So as you know, David, there's two types of cups now available. There's a spherical cup and there's a conical cup, and we haven't seen different results, outcome results in both, but there is a significant difference. For the spherical cup, yeah, the reaming. The position of the reaming of the cup is important, but the orientation is less important because you can still change the orientation of the cup when you insert it because it's spherical. So it allows some correction for the reaming that maybe wasn't in the right angle to the trapezium. If you use a conical cup, the reaming will decide the position and the orientation of the cup. And this is now cannulated. So that means that the guide wire that you put in the trapezium not only needs to be in the right position, but it also needs to have the right orientation, which then the right orientation for the guide wire is the axis of the thumb in neutral position, which is about 20 degrees of radial abduction and 20 degrees of palmar abduction. And it's in a 90-degree angle to what we call the PAST, is the proximal articular surface of the trapezium. So those are guide points that help you to position the wire. And then if the wire is perfect, then you can ream for a conical cup because then the cup will be in the right orientation. If the wire is not well oriented, you better ream for a spherical cup, and you can still change the orientation of the cup while inserting the cup. So it's a little bit technical, but I think if I see that most surgeons who start with this procedure are now going for the wire in the right position and then go for a conical cup. It's a little bit it's a little bit easier, I think, because you can rely on the wire, and once the wire is fine on X-rays, then you ream and then you position the cup exactly in the right spot in the right orientation. Second was. Tell me.
Did you learn any lessons from first generation that may have actually changed your results from the second generation, or do you think the technique and everything is exactly the same?
Yeah, I've been doing this for 20 years now, so I learned a lot over the years, because at that time when I started, training was very limited and we had to find it out ourselves, and I've gone through all the complications. So I've learned a lot doing this, and I think the evidence that's now available and the surgical technique videos that are available and the tips and tricks lectures from several experienced European surgeons are making training so much better and making the outcome so much better than what we experienced in the beginning. So I've learned a lot over the years, as you mentioned, removing of the osteophytes, exact positioning of the cup, and so many little things that avoid complications. So I learned a lot during that process. I did not change, I think, the surgical technique from the RPAs that we did included in this series, and the dual mobility that we included. The surgical technique there was very, very similar. So I did not use cannulated reaming at that time for the dual mobility cups, and I used the spherical cup in all the cases there. Yeah, which as now over the last 2 years I've changed to using more conical cups. But in this series, I think they're very, very similar, and I think the surgical technique was also very similar. Yeah. And then the question about capsular release, yeah, that's a good one. And we see experienced surgeons, all of them do it a little bit different. The French are doing very extensive releases and seem to have no problems with that. I try to release as much that is needed to get an excellent exposure of the trapezium. And that's essential. You need to have an excellent exposure of the trapezium, and you need to release the base of the metacarpal so that the exposure is fine. And that's for me, that's enough. I think the less I release, the less bleeding, the less scar tissue, and the less pain I will have afterwards. And then I will always try to close the capsule. I make a longitudinal incision, make 2 flaps, and then reinsert it at the base of the metacarpal. But there is no evidence that this is better. It's not needed for stability, but I feel just more safe when there is a barrier between the skin and the implant. So it's perfectly possible to close it. So I'll close it, but I will not make it too tight. So I'll check range of motion, and the closure should not restrict range of motion.
So when you make a longitudinal incision and close it side to side rather than trying to close it over from one bone to another.
Yeah, but I put a suture around the stem. Yeah, so when I introduce the stem, I'll put a suture around the stem, so I can reinsert the capsule on the base of the metacarpal.
Right.
Frederick, I have 2 questions for you, if that's okay.
Yeah.
First of all, in your paper, it seems that most of the dislocations, or all of the dislocations, occurred within 3 months of the first 3 months, right? And then I think in the literature it's been reported that most complications occur within the first 6 months of usage of a new implant. So my question for you, the first question is, do you have any advice on how to shorten the learning curve? Obviously, now we have technical tips and tricks, like how we have to make sure that the wire is perpendicular to the past, and we have to make sure that the reamer is right in the center of the trapezium. But do you have any other advice on how to shorten the learning curve for beginners?
Yeah, it's very easy. Just follow all the steps, and make sure almost every time when we see a dislocation, we find a surgical error that was made that caused the dislocation. Either the soft tissue balance wasn't right, the implant was too loose, or there was a remaining osteophyte that was impinging on with range of motion, or the orientation of the cup wasn't perfect. So you can really, if you get proper training, and I think the way it's organized now in the US, how it's introduced, I think nobody can start doing this without proper training, getting to know the tips and tricks and other little things that really can significantly lower the learning curve and the complication rate, I think. And I think now with cannulated reamers and with using more, in the beginning we did not use fluoroscopy, for example. So some cups were eccentric, some cups were less well oriented. Now using fluoroscopy, having cannulated reamers allows you to position the cup exactly right, and it significantly lowers the dislocation rate. So there's definitely a lot of things that you can do.
Thank you. And Warren has a question. Warren Hammett is asking about, can you talk a little bit about your post-op rehabilitation protocol, as well as return to activities, any restrictions after surgery?
Yeah, thank you, Warren. So we give them a bulky dressing for 2 weeks, just to be sure that the wound is healing well, that we don't have bleeding or infection or wound problems. So we keep that covered for 2 weeks. We see them back in clinic. We remove the dressing. It has a little splint at the thumb to restrict them from doing too much with the thumb. So after 2 weeks, we remove the dressing and we let them start active range of motion exercises. And we give them a removable brace that they wear intermittently when they're not doing the exercises. And we tell them that gradually, if pain allows, and if they feel comfortable, they can wean off the brace. And then we see them back at 6 weeks. Most of the patients at 6 weeks will have pain-free range of motion. We take an X-ray, and if everything's fine, we don't see them back. We tell them to be careful for 3 months with really heavy loads, so opening a jar or a bottle, that we tell them to be a little bit careful, but otherwise we don't give them any restrictions.
And I was wondering if I could ask you one more question about patients with more advanced arthritis and loss of trapezial height. Because I know with loss of trapezial height, the problem is then you don't want to go to ulnar. So when I was doing my training, I was advised to ream more radial, to place the cup more radial, and maybe even to have part of the cup exposed. So I was wondering if you have any tips and tricks for more advanced cases of osteoarthritis.
Yeah, so if we look at the trapezium, and what we will always do if we worry is take a CT scan to get a good view, and we get 3D images of the trapezium so that we have a good knowledge of the shape of the trapezium. And usually it's worn off on the dorsal side. Then of course it's very minimal resection of trapezial bone, just the osteophytes. So you don't want to remove any extra bone. And then you find the position. I will still position it in the center, and use a conical cup because we feel it has more initial stability than the spherical cup. And a part of the cup can be uncovered then on the dorsal side, which I've not seen to be a problem. So it works. It's probably not the best case to start. There's not the best cases to start with, but once you gain experience, you will start doing the more challenging cases, and you'll see that they do well. No?
And Dave has another question he put in the chat. Which X-ray view do you prefer to decide proper placement of the cup?
Good. So we'll take three views. We take a AP view of the thumb. We take an AP view. We take a pronated view, and we take a lateral view. But it's a lateral view of the thumb. It's not the hand. So it's a lateral view of the thumb. It's a pronated view and an AP view. Those three on those three views we look at it. We'll be having another webinar, and I think it's in 2-3 weeks for the ASSH on this, where we're all going into more details about this. But the views is really very, very important, and that's something you have to learn looking at the trapezium on fluoroscopy and evaluating the trapezium and the position of the wire. That's a little bit of a learning curve, but once you gain some experience, it becomes very easy.
Yeah, I saw that other webinar coming up, and it just reflects that there's so much interest in this topic in the US now.
Yeah, yeah.
There's one more question in the chat from Frederick Bellori, and it's kind of like a general question. He's asking, please discuss the difference in pain relief, range of motion, dislocation, and cost when using implants compared to trapeziectomy and other techniques of suspension plasty. And I think you answered some of this previously, but I was wondering if you wanted to add anything to this.
Yeah, so thank you for that question. So what we've seen, we've had a lot of visitors also from the US, and what we've seen, that what convinced them most was seeing patients in clinic after 2 weeks and after 6 weeks. To see that the little pain they had and the function they already had at 2 to 6 weeks is really totally different than what I was experiencing with my trapeziectomy patients. And I've done trapeziectomies for many years after my training. So the recovery is much faster. So pain relief, range of motion is definitely much better, and patients are really happy about this. And every study that I've seen comparing both is not. It's very difficult to show a difference in function. It's very different to show a difference in DASH scores or things like that. But if you ask patients, would you have this procedure again? Then about 90% of the patients with CMC1 arthroplasty will say yes, and about 75 to 80% only of patients that had trapeziectomy, and knowing that it takes much longer for them to come at the same level of pain relief and function. So definitely pain relief and range of motion is better. I cannot say something about cost because I know it's totally different. The system is totally different in the US than it is in Europe. In Europe, this is all, in my country, this is covered by a national security system. Dislocation rate is something that we are very, very happy that now that we have dual mobility implants, but because we feel it's almost non-existent. We had one case in our series, but maybe that was a little bit of the learning curve also from starting to use dual mobility implants, because since then we haven't seen dislocations, and we have not seen dislocations again. So I think dislocation risk is very, very low now if with a proper surgical technique. And I have little experience. I have little experience with all the other procedures that are set there.
And I wanted to ask you one last question. So if you encounter somebody with STT arthritis, is this an absolute contraindication, or are you willing to do the touch prosthesis with adjunctive procedures?
So if it's asymptomatic, we'll just do the touch. We'll just do the prosthesis. But we tell patients that there is a risk in the future that they may develop STT symptoms, and then we'll need to do something else. And I've done about 5 cases where I've done an STT fusion following a prosthesis. And STT fusion is my preferred treatment option for this. I'll do distal scaphoid resections, but I'm afraid of mid-carpal instability following this. So, but usually it's well tolerated, and we see a lot of patients with STT arthritis that are asymptomatic, and it's based on clinical examination. So we'll look at the CMC joint and move it, and then we'll palpate the ST joint and see whether it's painful, yes or no. And if there's no pain at the STT joint, even if it shows some degenerative changes on X-rays, we'll proceed with the implant, and we've seen good outcomes there. We're currently doing a study comparing those with the ones without STT osteoarthritis to see if that is also reflected in the results that we have.
Great, thank you so much. So if there aren't any more questions, I'm going to turn it over to Carl, who's going to moderate the next paper. And again, Frederick, thank you so much for joining us and for sharing your insights with us.
Thank you very much for inviting me.
Thank you.
Yeah, that was a great discussion. Thank you very much, and a wonderful paper. We're going to move on to the second paper of the evening. Out of Stanford, we have Dr. Chow, who's the senior author, and this article is entitled "Clinical Efficacy of Pulsed Electromagnetic Field Therapy on Thumb Carpal Metacarpal Joint Pain, a Double-Blind, Randomized, Controlled Trial." Ray, we'd love your presentation, then we'll have Dr. Roosh as our expert.
All right, thanks again for inviting me to talk about my paper here. Let me get my slides on the screen. All right, so yeah, this paper was a good collaboration with me and Dr. Amy Ladd as both part of the Chase Hand Center here at Stanford University. We're both really interested in non-operative treatment modalities, so we want to kind of explore a novel modality that's been presented for arthritis type of pain. So in terms of backgrounds, we know that thumb CMC arthritis does affect about 21% of people over age 40. As Dave was mentioning earlier, thumb CMC denervation surgery has been increasingly seen as a potential alternative to traditional surgical options to disrupt pain signals from the arthritic joint. And with denervation surgeries, we know there's multiple nerves involved in causing the pain signals from arthritis. And so those include the lateral antebrachial cutaneous nerve, the median nerve, and then the radial sensory nerves. So our thought with this is if denervation surgeries are increasingly seen as an option, is there a way that we can just modulate those pain signals rather than doing a denervation procedure? From that literature search, we came across pulse electromagnetic field therapy, or PEM therapy. What this is it came from pulse radio frequency, which was a treatment for facet-mediated pain in the spine, where conventional radio frequency was used to ablate the medial branches in the 1990s. So instead of ablating it with thermal energy, reducing the amount of thermal energy given so that it's just the electromagnetic waves are just given in pulses. And at the time, they found that that does help some patients with some of their pain. The thought behind why this works is that we think that the electric fields that were generated by that pulse radio frequency suppresses the excitation of the C fibers, which are usually in charge of kind of that dull, achy pain that occurs with arthritis. The specific device that we found was one that uses pulse shortwave therapy. So this is a slightly higher energy wave than radio frequency. So we're in the megahertz range rather than the kilohertz range. And this allowed for a little bit increased tissue penetration to about 10 centimeters in depth here. Studies on pulse shortwave therapy found that other than making sure that the parameters don't create thermal energy and delivering it in pulses, that other parameters regarding pulse rate, pulse width, duty cycles, those things don't seem to affect that much in terms of the clinical results. So from that, we decided to use the one that's most commonly prescribed and used in the literature. Some advantages of pulse electromagnetic field therapy over other therapies out there are that one, it's non-painful. So oftentimes people think electrical signal, how does that compare with TENS? With pulse electromagnetic field therapy, it's basically radio waves. So you don't feel much when the intervention is being done. It's non-thermal, so it doesn't cause tissue damage versus more conventional shortwave therapy treatments. And it's non-invasive. So traditionally, pulse radio frequency required placing a needle into the area that you're trying to affect. This one can be done externally. And with the currently available commercial devices, they also allow for home use because the energy levels don't get to the levels that can cause potential harm to patients. So with that, we wanted to do a very practical study on this. We want to see, since there's been studies showing that it helps primarily with knee osteoarthritis, will this also apply for thumb CMC joint pain? And the second is that some studies suggest that there is an analgesic effect that persists beyond the treatment period, and I want to see if we could confirm that. So the trial design is a single-center, double-blind, randomized controlled trial. We kept the inclusion criteria rather open-ended, with as long as they're an adult with age over 18, with clinical or radiographically diagnosed thumb CMC osteoarthritis, and an average pain level of between 3 and 8 to reduce ceiling and floor effects. And then we just excluded patients who are pregnant, who have recurrent infection or other hand injury, or any other hand pain, basically. We allocated them in a 1-to-1 ratio to use a device with active pulse electromagnetic fields or one that does not, but the appearance of the devices were the same. And we had the participants wear them for 4 weeks every night. Uh, and then we collected weekly surveys. And then after 2 additional weeks, we had them stop the device use and saw if there's any changes to their survey results. From this, we found that our primary endpoint, which was looking at the average numeric pain rating scale, if there was any difference at 4 weeks between the two groups, and that was not significant. However, if we looked at the week 6 data, so that's 4 weeks of use followed by 2 weeks of non-use of the device, that there was a significant difference between the two groups, with the ones using the active PEMF device showing persisting improvement in pain, while the control group went back to their baseline. This result persisted even though we had some patients who did use the device beyond the 4 weeks, which we can go into a little bit more detail in the discussion. And even though the two groups had no difference after 4 weeks of use, both groups actually showed significant improvements in pain score. So if it's at least suggesting something is happening in both groups rather than both showing no improvement in pain. And then other than that, we did not see a significant change in use of oral analgesics or thumb CMC splint use during those 4 to 6 weeks. So from this, we found that with our secondary endpoint, there was a significant reduction in average and numeric in pain scores compared to sham device use with using the PEMF device. So with that, we thought that there could be a sustained analgesic effect that's occurring. But there are some caveats to this. One is that the NPRS can show variation of up to 2.7 within a day. So our findings showed that the changes between 1 and 2. So that could be within variation. The second thing was that this change in NPRS was also less than what previous studies have shown. So this is a diagram from the study on knee osteoarthritis where we kept most parameters the same as what they had. But they saw in their case that the visual analog scale, the VAS, decreased by over 25%, which is higher than what we saw in our paper. And then the last part is that, yes, about 44% of participants in the PEM therapy group continued reported device use beyond the 4 weeks, We did not collect specific information about why that occurred, whether it's because they found that the device was useful and continued to use it, or if they've just forgot to discontinue it, or if they just reported it incorrectly. So that's one caveat that we would need to explain further in future studies. But from that, we think that it can be trialed as a treatment for patients who have persisting pain in their thumbs despite trialing other non-operative treatments. But I wouldn't necessarily say it's the first line based off the study that we've done so far.
Great, that was outstanding. Thank you for presenting that. And it's pretty rare in our field to have a prospective double-blind randomized trial for sure. So thanks for doing it. I would invite Dr. Roosh to give his expert presentation, and then we'll have some discussion.
I have to echo Kyle. You know, in our line of work, prospective randomized trials don't exist. They're not funded, and they're incredibly financially challenging for an institution to do. So I congratulate you guys for everything that you've done. This is fantastic, and is for us, it should be something that we should strive to do. I learned a lot from your paper because I really didn't have a great deal of experience with pulsed electromagnetic field therapy. So I kind of had to do a little bit of research on it. As you guys all know, we typically rely on, you know, the typical orthopedic treatment of splints, topicals, injections. And, you know, even when you look at injections, when we looked at a meta-analysis of injections, you know, not really any tremendous impact on what, you know, what you're actually injecting, whether it's HA, PRP, or cortisone, not really a big impact on it. So, you know, we really are limited in what we can use for CMC pain. All of our studies, though, show that with operative versus non-operative, that if your pain, when you pinch, decreases, your pinch strength increases, and your DASH scores are improved. And so we know that decreasing pain with pinch is what we need to do. So if you look at the PEMF therapy, there's a huge discrepancy between in vitro and in vivo studies on this, with a ton of laboratory studies showing profound suppression of inflammatory pathways and lowering cytokine levels and improving extracellular matrix synthesis. So it's great in your pet rabbit, but does it really work with your mother-in-law? And it's very challenging to really conclude that it does. There's several studies looking at the treatment in the shoulder, showing that there's no significant additional benefits in the shoulder, and yet there's several in osteoarthritis of the knee and cervical spine that show that there is a positive impact. So it's a challenging field to evaluate, and I applaud you guys for looking at it. My expert opinion is not really very expert because I am not an expert in this arena. But I would say that there is certainly very conflicting data on PEMF in humans, with many of the studies that are being published being funded by their industry partners. I would also point out that pain is incredibly difficult to assess, And pain range from 2.7 to 8 is a significant variation and is tough to quantify in a small series. I think your study does point out one thing that's incredibly important is that placebo can be very effective in the treatment, and that patients can have significant, in my estimation, significant improvement in their CMC discomfort based on what time of year it is, what activity that they're doing, whether they're wearing a brace or not. So I do think it's challenging to study this, and I applaud you guys for doing it. So I would say that I had a couple of questions. To what do you attribute the difference between the 4 weeks and the 6 weeks? There's no difference in the sham at 4 weeks, but there is at 6 weeks. Is that a significant time variation? And is that actually a clinically significant difference, as our friends in statistics like to point out? And then I do think that it's hard when 11 in the PMF group and 3 in the sham group reported using the device for longer, and could that account for changes? And in your discussion, you said that it would not, but in your paper, there is not a statistical analysis that demonstrates whether that would have been a difference. So if you guys could comment on that. And again, these are not criticisms, but more just I applaud you on everything that you've done, but I wonder whether other people are wondering the same questions.
Yeah, and I think they're fair. We were wondering some of these questions ourselves. We're fairly practical in our approach to this. Like we it's a new technology. We weren't sure of where this study would go. And then we presented this data. Then it was like, how do we interpret that data? So to your first question about why there were no differences at 4 weeks, but maybe at 6 weeks. So uh, thought that there were two things that we came up with in the discussion that could explain it. One was that the device itself could have like a splint-like effect. I have a This is what it looks like. It's an antenna. So if you put it on the hand, it is possible at nighttime that is kind of immobilizing the thumb CMC joint, at least partially. So during those 4 weeks, maybe they're both getting just kind of a splint type of effect that's helping their pain, but not necessarily something additional with the pulsed electromagnetic field therapy that was occurring at the same time. The second thought is that there could truly be a placebo effect going on there, that um, patients are looking for something to work to help with their pain, and during the first 4 weeks, they felt that okay, I'm wearing something that's helping, and then after those 4 weeks, in the 2 weeks that they're supposed to not use it, when they stopped using it, that placebo effect went away because they're no longer using that device, but potentially those who did those in the pen therapy group might have had something additional that was improving their pain, other than just either the splinting or that placebo effect. To your question about the non-compliance after 4 weeks, yes, we did find that to be kind of surprising to find when we looked back at the data that in the week 5 and week 6 surveys that patients were reporting that they were still using the device, even though we've mentioned multiple times for them to stop it after 4 weeks of use. So we decided initially we're doing a per protocol intention to treat analysis. So we included the all participants depending on how they were grouped. But based off of that question, we did run a small per protocol analysis of patients who followed the protocol of using it for 4 weeks and stopping it for 2. The significance value was 0.04, so still within significance, but certainly less significant than it was with including all the patients, all the participants in there. So as to the reasons for that, yeah, it could be issues with using the survey as a response and not being more diligent about making sure every patient stopped their device use. But we also have a potential question of, are the patients still using it because they did find it effective and that's why they continue to use it? And that we don't have an answer for based off of how we ran our study.
Great.
Great.
I appreciate it. There's probably some other questions out there.
Yeah, thanks, Dave. Ray, great presentation. I'm going to ask a question first, and this was about the timing of use. In the study, you had that participants use this at nighttime, and I would suspect that's for the obvious practical reason that this is the most the least cumbersome time for people to use this. But in a perfect world, do you think that there's a optimal cadence if it wasn't cumbersome and it didn't get in the way of people's using their hand? Do you think there might be a different cadence of use if the device were different?
Yeah, so that's a good question, and one that we don't really have a particular answer to. I know, like, pulse shortwave therapy, if done in a office setting, is actually done at like weekly cadences sometimes. Um, but with these home devices, the thought is that the more you can use it, the more likely that you're modulating the signal. So in the study we looked at that we based our design off of was one for knee osteoarthritis, and they used it for about 12 hours, and that's what the commercial device recommends is 12 hours of use. But certainly with the knee arthritis, you can wear that device without as much interference. With the hand, certainly not as much. So that's why we kind of, out of simplicity, kept it just for nightly use for that purpose. But yes, there is a question of whether those 4 additional hours a day would have made a bigger difference.
Great. We have a couple of questions in the chat, and we'll go through them kind of one by one. One of them is, what is the cost of the device, and how do you charge for treatment?
Yeah, so we are using a commercially available device. How the current company charges for it is in terms of number of hours of battery life use. So they sell it in terms of basically 1 month's worth of battery life use. So, well, it basically allows 720 hours of use of that device. In terms of the cost, it has fluctuated over time, but it's usually so far has been less than $50 US dollars at least for each device.
Okay. And then the two other questions were, how did you control for activity level of the participants? And did you control for orthotic use and the type of orthotics that people used outside of this study protocol?
In terms of activity level, we didn't control what they did. We said use the device as if, which is what I think most people would tell their patients too. So out of practicality, we didn't limit them specifically to what they were doing. But the thought was that potentially, like, if someone's more active, they're going to use it more. They're at least internally comparing with themselves there. For sorry, what was the second question? Sorry,
About the type of orthotics that were
Mhm.
used by patients, splinting and things of that nature.
Yeah, so again, we try to keep it a fairly practical study. So we just had them mark whether they were using a thumb CMC splint or not. Most commonly in our clinic, they usually use activity-based short thumb spica rather than a full thumb spica splint. But again, we didn't control necessarily for that. We just counted whether they reported they used a thumb spica or not, and compared that between groups as well as for if there's changes in use from before to after using it, thinking that if their pain improved, they would use the spica splint less. But that didn't show to be the case.
Great. So two additional questions, and if anyone else that's in the audience has questions, feel free to put them in the chat. But one question is, based on the results of this study, how have things changed at Stanford when patients present with thumb CMC arthritis? How is this being used as a treatment, whether it's primarily or secondarily? And then the second question is, where are you going to go with this research moving forward? Are you going to study this further, and how will you do that?
Yeah, great question. So in terms of changes in terms of practice, I think we still are primarily following typical conventional treatments first. So splinting, hand therapy, corticosteroid injections as needed. Um, for patients where those don't work, then I will bring this up with patients that this is a commercially available device that they can try to use at home and see if they are noticing any improvement. I tend to think, given that if we think that it's helping more with C fiber related pain, that it would work better for patients who feel kind of a dull, achy pain rather than those that feel it just like a sharp pain with movement, which would be more your A delta nerve fibers there. I do kind of counsel them that it might be helpful for certain types of pain, but not other areas. Um, in terms of the number of patients that have taken me up on trying it, maybe I would say kind of a handful, but it is something that I do bring up if everything else we've tried so far hasn't worked and they're not ready for any surgical intervention yet. In terms of where we're planning to do with this research, I think part of it is we are limited in terms of how many of these parameters with the neuromodulation that we can do. We're kind of reliant on what the commercial devices have. If we did talk at some point about whether to repeat parts of this trial to see if controlling for some of those variables will make a difference, or kind of looking back at the data and to see who are these patients who are more likely to be responders, and maybe controlling our patient variables a little bit more as well, in terms of like level of severity of the arthritis or the type of pain that they're having. So those are potential areas we're looking into if we were to kind of continue pursuing this. But from this study, we didn't see as big of a difference as we hoped we would. So um, we're still deciding on that stuff.
Great. Thank you very much for those answers. And, again, we all want to commend you on doing such an incredible study, which is hard to do in our field. I guess I will turn it back over to Harvey to give us some closing words.
Thank you very much, Carl. So I just want to remind everybody that CME can be claimed for Hand in Focus, and this can be claimed once every 6 months for all AHS webinars. And please follow AHS on social media. Please apply for AHS membership, and candidate membership for trainees is free. And also, AHS has a lot of exciting things going on. The one that's coming up immediately, or probably in like 3 months or so, is the Fellows Boot Camp. And this year is run by Carl and Glenn Gaston, and this really again promises to be a really exciting educational effort for your fellows. So if your hand fellows haven't signed up for this, please sign up for it. And it's probably a wait list, but please look out for this year and for next year as well. And the next AHS meeting is going to be in Miami from January 26th to 30th. And this is going to be a great meeting in warm and sunny Miami in the winter. So please mark your calendars for that meeting. Carl and me have been doing Hand in Focus for quite a while. It's been a number of years. And, I'd like to thank you, the audience, for tuning in for every edition and really supporting Hand in Focus. We're so grateful for your support, viewership, and participation. But we think it's time to turn it over to the next group of people. So I'm excited to announce that Neil Lee from Duke University and Kitty Wu from Mayo Clinic will be taking over Hand in Focus. And I am very excited to see what they're going to do with Hand in Focus moving forward. And finally, I'd like to thank my co-moderator, Carl. Carl, it's really been an honor and privilege to run Hand in Focus with you. I couldn't imagine doing this with anybody else, and I think one of the things I'm really going to miss about Hand in Focus is running this with you. I'll probably see you again shortly, but again, thank you so much for being a part of this journey with me. And again, I couldn't imagine doing it with anybody else.
And
So,
on behalf of the AHS, I got to say thank you very much to you guys for doing this.
yeah, thank you so much. And again, thank you, Carl. Thank you, everybody, for participating. And I guess we're going to sign off Hand in Focus for the last time and turn it over to the next generation. So thank you very much, everybody. Thank you, Dave, for joining us and our audience, and have a great night, everybody.